And the last talk will be about co-infection. So we already talked about diagnosis, we talked about comorbidities, complications, mental health, and the last one is co-infection. We know that STD is very common and we do it all the time because HIV and STD is combined. But earlier in this morning, we talked about chemsex, we talked about crystal methamphetamine, and now we see emerging hepatitis C cases. It might not emerging, but now we are more care about screening in our clinics. So today we have Dr. Pathariya Promsena. She's a pediatric infectious disease specialist, and currently she is working as a full-time researcher at Search Foundation, Bangkok, Thailand. She will share with us about hepatitis C co-infection in adolescent and young adult living with HIV. All you want to know about hepatitis from diagnosis and treatment and management. Please welcome Dr. Pathariya.
Thank you for the nice introduction. During the next 20 minutes, we will focus on the recommendations on simplified hepatitis C case finding and hepatitis C treatment in the context of an adolescent and young adult clinic. Hepatitis C is the blood-borne virus most commonly transmitted through sharing needle. Approximately 44% of new infections are found in people who inject drug, and the prevalence among this group in Thailand was about 36%. In addition to injecting drug users, MSM, particularly those with HIV infection, are at increased risk for hepatitis C. According to our study from Search Research Foundation, RE254 cohort, which enroll acute HIV participants since 2009, report an hepatitis C epidemic among acute HIV participants. Increase in hepatitis C incidence is mainly found in MSM, and the main risk factor for hepatitis C were methamphetamine use, group sex, and syphilis co-infection. HIV and hepatitis C is associated with higher rate of morbidity and mortality compared to hepatitis C monoinfection, and as chronic hepatitis C infection is often asymptomatic, screening is important to identify the case for early treatment to prevent progression to cirrhosis and reduce transmission. Let's start with the first case from the patient ABCD who should be screened for hepatitis C. Okay, most of you choose each side equally. And from the global immunization target for hepatitis C aims to reduce new hepatitis C infection and death by promoting the test and treat policy. The recommendations suggest all adults should be screened at least one time, and persons younger than 18 years with risk activity should also be screened, and also the pregnancy women also. And for the person who have ongoing risks, such as people who inject drug, MSM living with HIV who have unprotected sex, or MSM who is taking PrEP, should also have annual hepatitis C testing. So for the first question, A is people living with HIV, B has an unexplained AST/ALT elevation, C is a PrEP user and had history of multiple partner, and D never screened for hepatitis C. So each of these should be screened for hepatitis C. And initial screening typically begins with antibody test. For most patients, negative antibody test indicated no current infection. Then we should link the patient to the prevention service and retest if they have ongoing risk. If hepatitis C antibody positive, the confirmatory test by hepatitis C RNA should be done. And if the hepatitis C RNA is not detected, it likely represents a past infection with spontaneous clearance or maybe a false positive antibody testing. But if the hepatitis C RNA is detected, the diagnosis is confirmed, then we should link the patient to the treatment service. And as now we use the pan-genotypic direct-acting antivirals or DAA, so the hepatitis C genotype is not routinely required for the regimen selection. Several antibody testing are available, including the lab-based immunoassay, which is the standard test. And the other test that can be used for initial assay is rapid diagnostic test, which is useful to identify the hepatitis C antibody in point of care. And the test is cheaper, easy to use, and had good sensitivity and specificity. And on the left-hand side, you will see the hepatitis C rapid diagnostic test, which can use the whole blood from finger prick and can get result within the 5 to 15 minutes. And this is the study of Dr. Kritsani at Buddy CU Clinic and Adolescent Clinic in King Chulalongkorn Memorial Hospital to assess the prevalence of hepatitis C by using the hepatitis C antibody rapid diagnostic test with whole blood from finger prick. The overall prevalence of chronic hepatitis C was about 3%, and we found high prevalence in adolescents living with HIV and adolescents who use drugs. And only 10% of adolescents living with HIV has previously screened for hepatitis C. And the top reasons for not getting tested for adolescents were lack of symptoms and other barriers similar seen in adults. And let's move to the second case, a 24-year-old MSM living with HIV. He had history of multiple partner and inhaled methamphetamine use. He has no history of IVDU. The current ARV was TLD with viral load suppressed after 6 months of ARV. During the annual lab monitoring, the ALT was elevated and the hepatitis C antibody was positive. So what is the most proper management for this patient? Okay, most of you choose D. So hope that after this session, we will know how can manage the hepatitis C patient. The slide shows the overall management for hepatitis C patient. First, hepatitis C viral load should be done before start treatment. The second, evaluate the severity of liver disease, which is a key factor to determine the initial follow-up and the follow-up evaluation for the patient. Liver fibrosis assessment using non-invasive marker such as APRI score as shown in the slide. With we can use only the basic lab AST and platelet to compute the APRI score, or we can use the transient electrography or FibroScan if available. And third, evaluate host factor prior to treatment, such as the screening for co-infection like hepatitis B, HIV, evaluate the kidney function before start treatment, assess drug-drug interaction, and perform the pregnancy testing for female patients. And in the setting of adolescent clinic, most patients do not have advanced fibrosis since the patient has been infected for a short period of time. So the patient selection of regimen or treatment and follow-up can be simplified and can be implemented in the adolescent service. So when and whom to initiate hepatitis C therapy. As you will see that the all recommendation now suggest recommend treatment in all patients regardless stage of disease. The goal of treatment is to reduce all-cause mortality and reduce liver complications. A major barrier to hepatitis cure is the access to therapy, so there is still major gap for the hepatitis C testing and hepatitis C treatment. The antiviral therapy for hepatitis C has rapidly developed following the introduction of DAA. WHO recommends therapy with pan-genotypic DAA, and the DAA are grouped according to the target of action, and the recommendation of the pan-genotypic DAA are highlighted in this slide. In terms of the regimen selection, initial regimen for adolescents without cirrhosis can be selected without known hepatitis C genotype. simplified treatment with pangenotypic regimen of sulfonylurea, potassium, or Sofvel uh, once daily for 12 weeks is one of the preferred initial regimen for hepatitis C patients with non-cirrhosis or compensated cirrhosis. The software once daily for 12 weeks in Thailand, it's available in the fixed dose combination tablet called GPO Hep C and can prescribe one tablet daily for adolescent body weight more than 30 kilograms. And in Thailand, it's was approved for adolescent at 18 years and above and can reimburse from the NAP system. For the drug-drug interaction, there is no clinical significant interaction between Softwell and DTG, which is the current primary ARV regimen. But Velpatasvir is significantly reduced efavirenz concentration. So if the patient is still taking efavirenz, we have to switch the ARV to DTG at least 1 month before starting Softwell. In terms of the monitoring, since the AA are highly effective and has good safety profiles, so minimal on-treatment monitoring is appropriate for the patients who has no cirrhosis. And minimal monitoring include prescribed full course 12 weeks of the AA with support adherence and no any planned visits or lab testing required during treatment. In terms of the follow-up treatment, virologic response should be assessed by checking hepatitis C viral load. After complete treatment, the sustained virologic response or SVR is defined by undetectable hepatitis C RNA at least 12 weeks after the end of treatment. The SVR reflects effective of hepatitis C treatment and refer to hepatitis C cure, but it does not confer a lifelong immunity against hepatitis C. So the patients should be counseled that they are at risk of future reinfection and could monitor hepatitis C reinfection at least annually in the patients with ongoing risk behavior. For the ultrasonography and alpha fetoprotein should only be done in cirrhotic patients in order to monitor the liver cancer only. And for this patient, the hepatitis C viral load was done and confirmed hepatitis C infection. Evaluate the liver fibrosis using APRI score or FibroScan for this patient, and it showed this patient has no liver fibrosis. We simplify treatment with Softwell one daily for 12 weeks, and we assess the hepatitis C cure at 12 weeks after complete treatment, and the patient can achieve SVR12 with the liver enzyme turn to normal. You can now see the hepatitis C service delivery, including testing, treatment, and monitoring, which can also be integrated into our adolescent service. And the last case is a 22 years old MSM living with acute HIV in the RE254 cohort. He had history of multiple partner, multiple drug use, and the current ARV regimen is Triumeq, a study protocol. The viral load was suppressed and he had good CD4 count. He had hepatitis C infection in 2019 and was prescribed DAA. Then he can achieve SVR12 after complete therapy. We followed up the hepatitis C annually because he is still ongoing risk. However, the hepatitis C RNA remained undetectable. Until 2022, during the lab monitoring protocol, the ALT was elevated, and we repeat the Hep C RNA and it was confirmed hepatitis C reinfection. During a wait for treatment, the liver enzyme was going up and the ARV was changed according to the protocol. This patient received a second course of the AA from C-free program, and then he was able to achieve SVR again. This case demonstrates reinfection and in people who has ongoing at risk. And this is the study from RV254 acute HIV cohort also. It shows high rate of hepatitis C among MSM living with HIV about 15%, and the hepatitis C incident rate is 2.7 per 100% year follow-up. The spontaneous clearance was about 10%, and the hepatitis C treatment is accessible through the study protocol with a high SVR rate of 95%. Additionally, we also analyzed the data about the reinfection rate and found high rate of reinfection, about 15%, and with a short time to reinfection, about 1 year after clearance. So post-clearance follow-up with counseling and preventive strategy to reduce ongoing risk behavior are needed to reduce hepatitis C reinfection. In summary, the hepatitis C service in adolescents consists of simplified test, treat, and monitoring. The Hep C care should not be restricted only for GI specialists, but should be included in the adolescent service. Regarding the test, allow once in a lifetime screening for all patients and repeat hepatitis C testing in ongoing risk group. And for the treatment for all patients using the pangenotypic DAA. And in terms of the monitoring, assess kill by SVR12 and still retest hepatitis C viral load if the patient is still ongoing risk. And I would like to thank everyone that was involved in the study and support me for the presentation. Thank you.
Thank you so much. So I think in adolescent session, we have addressed many issues on testing, on PrEP use, on complications, on mental health, stigma discrimination, and also hepatitis C co-infection. So I think we have quite tense presentation, but I would like to use the last 5 minutes for the audience to share your thoughts or ask the questions to the speakers. Please.
Could be any question.
Or share your experience in Vietnam, in Cambodia, in Philippines. We are very welcome.
Yeah, please, Garrett, please.
Thank you. Gareth Tudor-Williams from Imperial College in London. This has been a really, really interesting afternoon. Thank you to everybody. And I just have one quick question for Satish. You know, we've heard a lot today about U equals U, including people nearly losing their medical license to practice by promoting U equals U. And yet that didn't come out of the cohort study that you described. And I'm interested to know whether that's because U equals U does not translate in Thai and it just simply has no traction in the clinic population. Or, well, please tell me.
Yeah, so thanks so much for the question. So around U equals U and whether that was a factor in people deciding whether to disclose their status. So we asked them a series of statements, and one of the statements that we asked them about actually was whether U equals U had any impact on their decision to disclose, and it was quite split, sort of 50-50. Some people felt that it had impacted, and some felt that it wasn't a factor. But in the interviews that we've conducted, many people spoke about U equals U, and they explained that while it was helpful for themselves and sort of the comfort and confidence that they had in themselves around transmission, it wasn't significant in telling the other person, and it was more about the recipient factors and the sort of interpersonal factors that decided whether they want to disclose or not. That was my understanding.
May I add some comments? I think in Thai culture, the internal stigma is the one that is important. In Asian culture, we are more internalized. And I think U equals U is help them for internal stigma. I'm not dangerous, I'm not contagious. But in order to explain or using that is U equal U, it doesn't mean that I don't need to explain anyone because I'm not infectious. It's not the way that our adolescent, the angle that they perceive about U equal U is more on less internal stigma and less feel bad about themselves.
And I think it's also on the knowledge of general population. I think several people still feel that HIV is a death sentence, and it's quite unbelievable to them that, oh, you equal you is real, something like that, and it's true that it's very difficult to translate you equal you into Thai, so we use you equal you even for Thai people. we don't have the very unique words for that. Yeah. And but that's very, very important that we should encourage you equal you to be part of the reason for disclosure. Yeah. Is there any question? Yeah, please.
Hi, a very good evening to everybody. I'm Dr. Satya from Ministry of Health Malaysia. I'm a family medicine specialist who is doing subspecialty in communicable disease in primary care. So the question is to actually Dr. Kumar. Dr. Kumar, it's quite clear that in adolescence, we have the perinatally acquired that come over to the adult clinics, and also we have the behaviorally acquired HIV. Consent is a big problem in Malaysia. Our Child Act needs a lot of amendment. I don't think we are going anywhere very soon. Age of consent for an adolescent is 18 years in Malaysia. So a lot of them who are behaviorally acquired, they do not come with their parents. So tell me, you have 20,000 cases you treat from womb to tomb in your clinic with 20,000 patients. How do you handle this in your practice? Thank you.
It's a very difficult question. I know this particular chapter itself is every day is a learning lesson, right? We have counselors working with me for 20 years who can write a textbook on from every case, and they go to conferences, BL conferences, and present 5 different cases, and they get the best paper award. Every time they do that. So it varies from individual to individual. Again, now we have legal systems in each country. Even in India, we do have. So, and also the parents are different. They are educated, not educated, conservative, upper caste, lower caste, different religion. We have all types of things in my country. So one size doesn't fit for everybody, so no proper answer I can give it to you. But each one we have to design our own. So we also learn from our previous counseling sessions, with a child or with adolescent or a young adult, what we learn from them, what they expect, what their reactions, and when we do that, then we try to replicate, because this is another new area of science. No, we don't have a textbooks to teach us. So because this comes from practicals, and again, this changes from year to year. So many years back, when I started my practice, we started. I know some of the clinicians here. We have only AZT, AZT3D, CDD, a couple of drugs. Then after that, we lost patients after 7, 8 years of things. So what do you do to these? When they say what therapy you have? Now we have better tools. So that's what U is equal to U. So we are did trials like HPT and O52, several other studies showed that. But now we have a WHO guidance. I think that's something what we can, use this type of tools to do a better decision making, even with their parents. Not with their, adolescents or young adults, even with their parents also. The first question in my clinic they'll say is, hey, they have HIV, will they get married? Can they have child? Rather than their lifespan and anything, this is something their immediate needs, to talk to the societies. I think this type of things need to be there. Again, varies from culture to culture. In your country is different, my country different, Thailand different, China is different. So I think each country and each clinics, we have to develop our own, model. There can be a basis, but something has to be figured out. That's what one size doesn't fit. I can't give you a perfect answer. But on the other hand, what we have learned over a period of now decades is, this is something should be addressed very heavily. Otherwise, we will not be able to manage this population very well, because they are going to live forever. Now we have therapy which can take to them. So how we are going to move them along with it? That's what we can learn from pediatricians, because these are the kids with them. 2 years, 3 years, they have groomed them up, to those years, not really just on this, but on various other aspects, how we can use that in our practice, how we can impart on them. I know it's a very difficult thing. I think now with the new drugs, again, now some of the challenges is long-acting injectables. So suddenly, how are you going to change to them? It's better, in fact, instead of taking everyday tablets. But again, giving an injection shot which they are going to rub their butt, then they may not come here. This type of challenges, everywhere there is a challenge. I think we need to work on. I think very, very different. And also now with a better social media and other things, some of the things are a little simpler, but that can be harmful also. So how you can, in fact, in my clinic, we have a counselor who talks only about these fake social media things. Don't believe all this. Even first encounter is said, this is something spreading. You may get across in your WhatsApp or in Telegram or Instagram. Don't believe on this. And I think this type of counselings, we do also. A certain type of therapies. We have certain alternate cures in my country where called magic cures. They talk to them because they all go into that and get experimented. If you don't do that, I think this is something what you have designed in your clinic based on the needs of this population.
Thank you. Well, in Thailand, we also have the age of consent at 18. However, for HIV prevention, treatment, diagnosis, we use some other mechanism, and you should do the same thing. We use the mechanism of medical council, and they have issue that for such thing about HIV, you don't have to worry about the 18 age of consent. Yeah, so you should find a mechanism in your setting to find a way out that no matter what age they are, they deserve diagnosis, treatment, counseling, prevention, and everything, including reproductive health. Yeah.
Any addition, comment, suggestion, or sharing how you're going to take the cases, the knowledge, or the tips from 7 speakers back home to your clinics, to your colleagues? You can share of anything or reflection of what happened in this afternoon with the 7 topics that we cover. Please, we are welcome a couple of more questions or comments. Anyone, please?
Okay. I think it may be time. All right. Well, I think we learned a lot, and obviously we're gonna be here another 2 days, so you get to meet all the speakers and everyone here. And please feel free to exchange, and it's good to learn and to share. Thanks so much for all the speakers and the participants. See you tomorrow. Thank you.